Thank you very much. Good morning, everyone, and thank you to the organizers for this opportunity. I have to confess first off, as a pediatrician, I have never spoken to an audience of adult pulmonologists and physicians, so this is the first. Okay, so moving away from tuberculosis into something completely different. This is an area in which there's been an explosion in research in the last 4 years. So the microbiome, basically 100 trillion friends that you didn't know you had, and these exist in you and on you. And in case somebody wants to know, you can't make friends with them on Facebook. What is the human microbiome? It's the genetic material of all the microbes that live on and inside the human body. All of the microbes combined weigh about 1.36 kg. So for anybody out there who's trying to lose weight, just remember, almost 1.5 kg belongs to your microbes. There's more microbial cells which live inside the human body than there are actual human cells. So 90% of the cells within and on the human body are actually microbial. The digestive tract is the largest, and it houses about 99% of the microbiome. This is where the organisms live. In your airways, on your skin, in the urogenital tract, and in your GIT. So looking at some of the benefits of the microbiome, mainly those linked to the airway, the microbiome harbors nutrients. It prevents colonization by pathogens by competing for attachment sites. It may antagonize other bacteria by the production of substances which kill or inhibit non-indigenous species. It stimulates the production of cross-reactive antibodies. It provides resistance to some forms of cancer, and it is very critical in assisting in developing a mature immune system. How and when the microbiome develops is still under much discussion. There's debate as to whether it develops in utero or whether it develops during and after birth. Looking at the gut flora in human infants, it was thought that the GI tract of the newborn in utero was sterile, but there is much work being looked at now which thinks that may not actually be true. It is known that during birth and shortly after birth, the bacteria from the mother and the environment colonize the infant's gut. The birth canal also supplies the newborn with the bacterium lactobacillus, and this is very important in the development of the immune system. Whereas babies who are born by cesarean section actually get their microbiome and organisms from the doctor's gloves, from the nurses, from staff in the theatre, from the environment in the theatre, and this is not a good microbiome for the newborn. So what affects the development of the respiratory microbiome in the newborn and infant? It is thought that it's the organisms which migrate during pregnancy. So what we do know is that during pregnancy, organisms from the mother's GIT actually migrate into the vaginal canal and into the mammary gland. And these organisms are passed on to the baby during the time of delivery and through breastfeeding. If there's chorioamnionitis, infection of the placenta during pregnancy, that might impact on development of the microbiome. The mode of delivery is important in what the baby obtains. The rates of microbial inhalation, immunity, and interaction between microbes. The airway microbe at birth. So like the gut microbe, it was originally thought that the airway microbe, the airways are actually sterile at birth. But again, there's new research now which suggests this might not actually be so. What we do know is that the microbiome is already present. Well, what we know now is that the microbiome is already present and diverse at birth. And this is a study that was done by Rad et al. What they showed was that there was a microbiome at birth. It was similar in term and in healthy preterm infants. And what they also found was that infants who were extremely preterm and who subsequently developed bronchopulmonary dysplasia had a microbiome which was actually dysbiotic right from birth. So basically they didn't have much chance. They also showed that in pregnancies where there was chorioamnionitis, there was a decrease in the lactobacillus and subsequent lung disease. Lactobacillus seems to be associated with many problems of the airways. How does mode of delivery affect the airway microbiome? I've already shown you how it affects the gut microbiome. This is a prospective study that was done by Bosch et al. And what they did was they took nasopharyngeal samples from birth for the first 6 months, and they analyzed these samples. And what they found was there was quite a significant difference between those born by vaginal delivery and those born by cesarean delivery. Infants who were born by cesarean section actually had an instability of the microbial profile, and they had a lower abundance of beneficial organisms. And it was thought that this is what made them more likely to develop respiratory tract infections. They followed up these infants, and their parents recorded the number of respiratory episodes as well as the number of respiratory associated hospital admissions, and this is what they found. The role of vaginal seeding is interesting. So there's work from the UK. I think there was, I'm sorry, I can't remember his name, but there's an obstetrician from the UK who started off this trend. And what he did was, in babies who were born by cesarean section, he took swabs from the mother's vagina and smeared the baby, the newborn baby, with these swabs in the hope that they would get the good microbes from the mother's vagina. And there's been a lot of criticism, there's been a lot of takers. Now there's a prospective study that's being conducted to actually look at this and whether there would be an impact from doing this process. So looking at the microbiome and lung disease in children, most of the work has been done in asthma, in cystic fibrosis, and in bronchiectasis. This is a study by Hoon et al. In which they looked at the association between gut microbial colonization in early life and respiratory outcomes in cystic fibrosis. So just to start off by saying that there's major interactions between the gut microbiome and the respiratory microbiome. In this study, they followed up infants who had a diagnosis of cystic fibrosis, and they were followed up from birth to 34 months of age. Specimens were taken both from the airways and from the gut, and they were taken serially over the 34 months. And what they found in the study was that there was a core microbiome in both the respiratory system as well as in the gut, and this was present from birth. They also found that there was increased diversity. They also found that if there was an increased diversity of the microbiome, that was associated with prolonged periods of good health, delays in time to initial colonization with Pseudomonas, and delay in the time to the first exacerbation of cystic fibrosis. They also found that if infants were breastfed, they had an extended period to development of their first exacerbation with cystic fibrosis, as well as to colonization with Pseudomonas. And finally what they found was that there were specific groups of bacteria in the gut and in the respiratory tract which predicted the onset of respiratory complications in patients who had cystic fibrosis. So they found that in the airway there was an increase in Salmonella just prior to the patient becoming infected with Pseudomonas. And they also found that there were certain organisms which actually decreased in the stools of the patient, which predicted the initial colonization with Pseudomonas. And we all know that in children as well as in adults, colonization with Pseudomonas is a big problem in cystic fibrosis. The other area where there's quite a bit of work is microbiome and allergy, and again this association between the gut and the respiratory system. So there's new research which has shown that the type and mix of gut bacteria as well as the upper respiratory tract microbiome profile in the first 6 months of life has a profound effect on the developing immune system and the risk for allergy and asthma later in life. So there's quite a big study that was done called the Wheel study. I'm not sure there's anybody here who might be involved in that study. It was a series of 6 studies in which they took stool samples and blood samples from 298 children who were under 12 months of age. This was the first human study that showed an association between microbial diversity in the infant gut and the development of regulatory T cells. It also showed that breastfed babies had diverse bacteria in their microbiome compared to formula-fed infants, in particular the organism Lactospiraceae, which is important when it comes to pet allergy. It also showed that the microbiome had an impact on nocturnal asthma, and these series of six studies concluded that from an early stage in life, there is evidence of dysbiosis in the gut of infants who develop atopy and asthma. More recently, there was a study by Theo which looked only at the respiratory system, and what they showed was that viral and bacterial communities in the nasopharynx impact on the development of asthma, and if there was early colonization with Streptococcus, it was actually a strong predictor for the development of asthma. So, considering that, if one considers tweaking the microbiome, can we actually prevent the development of allergy? And that's an area of future research. So if we did something to the gut microbiome, could we prevent a child from developing allergy and asthma later on in life? It's a very interesting area. Moving on to the microbiome and the lung in adults. The sources of microbes in the lungs in adults, well, I don't have to tell you that, but what's interesting was that when they looked at bronchoalveolar lavage samples, they found that in an individual who is healthy, the microbial load in the lungs is low, and samples from the lavage contain a predominance of bacterial taxa which is found in the mouth. And they also found that the bacterial diversity in the lungs is very low, so that makes a healthy individual. However, when there's disease, the microbial load in the lung increases. The bronchoalveolar lavage samples show numerous bacterial taxa which is not found in the mouth. So these have obviously migrated from somewhere, and the possibility is that's from the GIT. In subjects who are healthy, the most commonly reported bacterial phyla in respiratory specimens are Bacteroides, Firmicutes, and Proteobacteria. Interestingly, they found the lower respiratory tract communities, whilst they are related to those in the upper respiratory tract, they have their own distinct communities. And with these new techniques, remember that in the past we used culture and culture techniques. Now they've developed a whole host of new techniques which can identify organisms which are not just standard microbes. So they've uncovered a whole host of new pathogens which are related to exacerbations in cystic fibrosis. They've also found that various disease states have revealed distinct lung microbiota with altered diversity in patients who have cystic fibrosis and COPD, for example. They've also found alterations in the lung microbiome constitution and diversity have been associated with clinical parameters such as disease severity, airway obstruction, and exposure to antibiotics. This is what you would find in a healthy individual versus individual who has asthma and an individual who has, for example, cystic fibrosis. So you can see that the type of organisms and the diversity of the organism changes as you get disease. So you have fewer, less diverse organisms when you're healthy, and then you get more organisms and much more diversity during disease. Some of the diseases which have been studied and have found to be associated with the microbiome in adults include cystic fibrosis, asthma, COPD, bronchiolitis obliterans following lung transplantation, cancer of the lung, and also most recently ARDS. Just a few words about cystic fibrosis in the adult. It is now recognized that the microbiome of cystic fibrosis is complex both during and between exacerbations, and that the use of antibiotics during an exacerbation may actually alter the dynamics of the microbial community. So what some studies have shown is that the antibiotic that you are using may not actually clear the infection, but it might shift the entire microbial diversity, and that might be more harmful to your patient. They've also found that recent antibiotic use is a strong predictor of decreased microbial diversity. And also that there is a decrease in the diversity of your microbiome in patients with cystic fibrosis, with advanced age, and with severity of the disease. In COPD, there has been quite a bit of work recently, and there were 7 recent studies. By recent, I mean in the last 4 years, which have looked at COPD and the microbiome. And what they have concluded from these studies is that the lower airways and the alveoli of patients with COPD contain a distinct microbiome. It may impact on both the progression of disease as well as on the development of infectious exacerbations. And they looked at specimens of patients with COPD and found that there was quite a big difference in the microbiomes of the organisms of these patients. They also took samples in patients from individual patients from different areas of their lungs, and what they found was that if in a patient who had severe disease, there was actually quite a big difference in the heterogeneity between the different areas of the lungs, which is quite interesting. But they also found that there were certain organisms which are common among patients with COPD, in particular the Pseudomonas, strep, and Haemophilus. This was a study by Dixon, which was recently published, which looked at enrichment of the lung microbiome with gut bacteria in sepsis and the acute respiratory distress syndrome. And this study, it was in 2 parts. The first part was in ARDS with humans, and the second part was an experimental sepsis in mice. And in the first part, in which they took bronchoalveolar lavage specimens from humans who had ARDS and used new techniques to identify organisms, they found, in fact, that gut-specific bacteria were common in these patients, in particular Bacteroides. They also found that alveolar TNF-alpha, which is a marker for ARDS, was significantly correlated with an alteration in your lung microbiota. So this is very new work that has come up. Then what they did was that they took mice and they created sepsis in these mice and looked at the specimens from the lungs, and they found that the communities in the lung were actually dominated by bacteria which came from the gut. So again, that association between the gut organisms and respiratory disease. Just to mention the lung microbiome in HIV, being an infectious disease person, I can't escape HIV, and in South Africa we can't escape HIV. This was a work that has been initiated by the National Institutes of Health in the USA. It's the Lung HIV Microbiome Project, and it's a sub-component of the Human Microbiome Project. Some of the work that has already come out from this project has shown differences in the microbiome in those with advanced HIV disease. They have found altered alveolar microbiome. It's more sparse, it's less diverse, it has a higher amount of signature bacteria which are associated with lung inflammation. And they looked at patients who were receiving antiretroviral therapy and found that there's some improvement or change with antiretroviral therapy, but the patient's microbiome doesn't revert to baseline even with treatment. And interestingly, they've also studied the alveolar virome, and they have found differences in patients who had HIV infection. So moving on then to the last part, which is microbiome and therapeutics. And there's 3 areas in which the microbiome is being looked at. It's probiotics, fecal microbiota transplantation, and antibiotics. So you all know about probiotics, you all know about using probiotics, and we all know that it's used in GIT diseases, particularly in patients with Clostridium difficile. It's used for irritable bowel disease. In pediatrics, it's been used for preterm newborns and those born by cesarean section, and it's recommended for formula-fed infants. But when it comes to the respiratory tract, there's very few studies that have actually been done, and those few that have already been done suggest that there may be a benefit using probiotics in patients with ventilator-associated pneumonia, with upper respiratory tract, with recurrent upper respiratory tract infections, and during an exacerbation of cystic fibrosis. But obviously, the probiotic that's used has to be developed specifically for the organisms that you think are involved in these conditions. You have to tweak whatever's available so that it's more specific. But what's more interesting, and which is now going to be an area of new research, is can we take a probiotic and develop it in such a way that we can actually instill it directly into the airways of the patient, say with cystic fibrosis, and would that affect the microbiome in the airway and therefore lead to an improvement in the patient? The other big area when it comes to the microbiome is fetal microbiota transplantation, and this is where the gut microbiome from a healthy donor are infused into the intestine of a recipient. So what happens is samples of stool are collected, they're treated, and that sample is then infused into the patient. And this is done either by a nasogastric tube or through development of capsules. These stool samples, which are collected from healthy donors by a very, very stringent questionnaire, just like with blood transfusion, etc. Samples can be stored. Stool banks have been established in some parts of the world. There's a lot of work going on in it. Currently, it's used mainly for Clostridium difficile and irritable bowel disease, but there's a potential it can be used for things like obesity, neurological diseases, and when it comes to the respiratory system, there are already studies which are being developed in which the gut microbiome from a healthy donor will be transfused into a patient with cystic fibrosis, and then whether it's going to make a difference to that patient is what they're going to be looking at. But again, more interestingly is, okay, so you can do that with the gut microbiome. Is there a way that we can take the respiratory microbiome and develop a system of infusing it into the lung of the patient with cystic fibrosis or COPD or asthma, and will that make an impact on that patient's condition in the future? And then finally, the microbiome and antibiotics. So there's a wave of investment from pharmaceutical companies which suggests that drugs from body-dwelling bacteria are heading for the clinic. So what we're looking at now is that the human microbiota are now being evaluated as a potential source for new antibiotics. We've been through every other possible source for developing new antibiotics. The future is actually that your own organisms are going to be the area where new antibiotics are going to be developed. And in Nature in July this year, there was an article that was published which found that the organism Staph lugdunensis, which is normally found in the nasal passage, actually produces a peptide antibiotic that inhibits Staph aureus. So this is very exciting because is this a potential new treatment for something like Staph aureus? So in conclusion, what we're saying is that it seems that the gut, organisms in the gut exert a major influence on respiratory disease, and in the future it may be that it's your gut that's actually going to be treating your lung. So thank you.
Any questions? Questions or comments?
I think there have been some studies of probiotics in asthma, in children.
Yes, that's what I said. There is some work.
There have been some studies which haven't really been very conclusive. But I think there's a lot of work to determine what sort of
the best choice.
What sort of probiotics to use. I mean, you mentioned lactobacillus and that sort of thing. And also there have been studies where they added probiotics, prebiotics to probiotics, like some products of those bacteria together. I think there's probably a lot of work to do before this will become successful. I mean, how long you give it, and whether we need to give it in by inhalation, perhaps. I don't know for the lungs, but I think by inhalation is going to be quite a challenge. I mean, because we don't know what those lactobacillus and all the bacteria can do in the lungs. I mean, can they actually infect? I don't know. I mean, in the gut they seem to be okay, but in the lungs we don't know. So it's really a very exciting area. And the comment about antibiotics is very pertinent. I mean, we use antibiotics to kill the Haemophilus that's causing the problems, but it's also changing the state of the rest of the microbiome in the lung and also in the gut. So these are comments that I just to support all this concept that is really useful. I think there will be lung disease.
Maybe in SPOI in 5 years' time we'll have a little bit more positive.
And also the idea of the shit banks is quite interesting, and I don't know how many of us would like to have our fecal microbiome, our fecal microbiome. So anyway.
It'd be nice if you can treat TB.
Yeah, I was going to ask you, what are the changes to microbiome TB?
Absolutely. I have not any information on tuberculosis at all. I don't think anybody's done any work with TB. Not at all.
Okay, any other comments or questions? The question in the back there.
Thank you, I enjoyed the talk. Just in terms of new fad, amongst celebrities to do colonic cleansing, do you think that's going to affect our microbiome and future disease spread?
I don't know that I don't know, and I can't answer that, but yeah, well, let's put it this way, we won't take samples from celebrities for the stool bank, but that would.
When we were small, we got punished by getting castor oil, did that?
What about your guidelines for the misuse of antibiotics?
You can see how critical it is, the misuse of antibiotic and antibiotic stewardship. So obviously being pediatric infectious diseases doctor, to me that's critical component of what we're doing to our gut and how we're altering. And you've seen that Clostridium difficile is one of the most difficult conditions to treat. And so much work is being done on that. But as you mentioned, even with TB, if we close the tap right at the beginning, then we're not going to have this problem of antibiotic resistance and all the problems associated with it. So.
When you talk about probiotic, what kind of probiotic do you suggest?
Well, as I said, it has to be developed very specifically. It's not something that you buy off the shelf in the supermarket. They have to be developed very specifically, taking into consideration what microbes you want that patient to receive.
Thank you, enjoy your talk. Raziya, now, concerning asthma, for example, to fight against atopic, we send pregnant women in farms to get in contact with germs, which can help. What is your say about that?
Actually, it's very interesting that you ask, because taking it in a different way, you know, there's this, we've always had this concern that when there's a newborn, keep everybody away because you're going to make baby sick. But what they've actually shown was that, for example, you know, with Indian families, you know that when there's a new baby, the whole community almost descends on that baby and it gets passed around and whatever. And that's actually very good for the baby because then the baby is getting normal microbiome and normal organisms that protect the baby from future development of things like allergy. And we know that it's urbanization that has made a big difference to patients developing allergy. So yes, going back to the farm, getting your hands dirty, being in there seems to make a difference.
And encourage couple to kiss, no?
As long as they have.
Okay, any more questions? If not, then thank you very much for your attention. Rather, we'll come back in half an hour.
Yes, half an hour.
Thank you.